Hello everyone. In today's lecture, we will continue from where we left last time. So last time we had seen the structures, the muscles which were forming the boundaries of the anterior triangle. So first let's revise that and then move forward. So the side of the neck, which was a quadrilateral, was divided by the sternocleidomastoid into two triangles, the posterior triangle and an anterior triangle. The anterior triangle, we further divided into two parts, a suprahyoid part and an infrahyoid part, on the basis of the muscles and the presence of the hyoid bone and the structures which were attaching to the hyoid. The suprahyoid part was divided into two triangles, a single submental triangle which was shared by both the sides, and a digastric triangle on each side. The digastric triangle was bounded by the anterior belly of digastric anteriorly, posterior belly of digastric posteriorly, as well as the lower border of the mandible, and an imaginary line running from the mandible to the mastoid process. So this out here is the digastric triangle, whose boundaries we've seen the structures which are forming its floor, but we need to see its contents. Similarly, in the infrahyoid region, we had two triangles, the muscular triangle and the carotid triangle, which were separated from each other by the superior belly of omohyoid. The superior belly of omohyoid formed the anterior-inferior boundary of this triangle, which is the carotid triangle. The posterior superior boundary was formed by the posterior belly of digastric and the stylohyoid muscle, which is running along it, but coming with from the styloid process. And the posterior boundary was formed by the anterior border of the sternocleidomastoid. The floor of both these triangles was formed by structures which were, or the muscles which were wrapping around the laryngeal and the pharyngeal structure. So they were a part of the larynx and the pharynx, and these were muscles which mainly are gaining attachment or origin, or one attachment is outside and one attachment is on the framework of the larynx or the pharynx. So one such muscle which was forming the floor is out here. This is the inferior constrictor. This is forming the floor of the carotid triangle. Then we also saw another muscle which was the middle constrictor, which is also forming the floor of the carotid triangle, along with this muscle which is number 44, which also peaks into this area, which is the hyoglossus, which will be peeking out here. Right? So, and the thyrohyoid muscle. So all these muscles were forming the floor of this particular triangle, which is the carotid triangle. And in this is present the neurovascular bundle. Now look at the digastric triangle. So in the digastric triangle, we had these two muscles, it's number 6 and number 44. So this number 6 is the mylohyoid muscle, which is forming the floor of the digastric triangle, and the other is this hyoglossus muscle, right? So the hyoglossus, the name tells you, it's going to move from the hyoid bone to the tongue, which is glossus. Mylohyoid. So from the hyoid bone to the mylohyoid line, which we saw on the mandible. So the name does tell us a large part of its origin, insertion, or it tells you about the action which it would be bringing around. For example, inferior constrictor of pharynx. So it's going to bring about constriction of the pharynx. So depending on what is their function or on the basis of their nomenclature, they have been named. It does seem difficult at the beginning, but again, you'll get used to it. It'll become a part of you. So these two triangles are made up of muscles which are making its boundaries and which are also forming the floor. And that's what we are going to study. Now, in these triangles are present this neurovascular bundle which consists of the carotids, the jugular, as well as the branches, the cranial nerves and branches of the cervical plexus. Now, one such thing, can you see this U-shaped loop which is present, which is over the carotid structures and the internal jugular vein? This ansa cervicalis we've already seen. This was what was supplying the muscles of the muscular triangle. We've already seen that. So some structures we've seen, and as I said earlier, the structures will digress and move from one triangle to another. But we are going to study the triangles to give us an idea about what structures are likely to be present in order to solve cases like I'm going to discuss in the next slide. First we'll go over the competencies which we'll be covering. So we will be studying or demonstrating and describing the origin, paths, course and branches of the carotid arteries, as well as the subclavian artery in the neck. So the subclavian artery just peeps into the neck, but it gives branches, and the carotids, along with the branches of subclavian artery, are ultimately responsible for the entire blood supply which is coming to the neck area. Describe and demonstrate origin, course, relations, tributaries, termination of internal jugular and brachiocephalic veins. Now coming on to that case, why do we need to study? The question which always plagues us when we are studying anatomy is, why do we need to have so much of information? So a 59-year-old gentleman comes to the neurology faculty with the complaints of slurring of speech and weakness and numbness which he felt in his right arm for the past 4 hours. Now on examination, after having elicited the appropriate histories, I'm not going into the details of everything else. On examination, the physician or the doctor in charge hears a bruit, a carotid bruit in his neck. He hears it on his left side. See, right arm में weakness और numbness थी, slurring थी, but left side में उसको एक carotid bruit, I can hear a carotid bruit. Now, what do you mean by carotid bruit? That is a murmur. Usually, the blood is supposed to flow normally through the blood vessels. Now, in case the blood vessel the passage of the blood gets obstructed due to certain structure which is present in the blood vessel or a plaque which is present, an atherosclerotic plaque. Now, this would decrease the passage of blood or the flow of blood which is taking place, or ensure that the normal flow of blood is not there. As a result, the blood, जैसे पानी भी अगर एक constriction के through आता है तो आवाज कहते हैं करके, similarly यहाँ पर भी blood के flow में एक आवाज आती है जिसको हम कहते हैं एक murmur सुनाई दे रहा है. So this murmur or in the carotid is known as the carotid bruit, which is also can be confirmed by doing a Doppler color flow study. So the aim to treat this particular gentleman would be to remove this atherosclerotic plaque which is present in his carotids. And in this case, we can see that it's present in the common carotid and it's going on to the internal carotid. The internal carotid is the structure which is supplying the cerebral hemisphere. So we'll be supplying the brain. So our aim is to remove this plaque. Now, to be able, which an interventional cardiologist will do, so be able to do that, we should know the anatomy of the structures which are present around these vessels, so that while he's clearing up this plaque, he does not end up giving another injury to the patient. So the aim is, so this is one of the scenarios in which the anatomy of the triangle becomes very useful to us. So as we've already seen, we'll again see in this cross section, these are the structures which we are now going to be studying, which are present posterior lateral to the viscera of the neck. And they are protected by these muscles, the sternocleidomastoid, the muscular triangle. Although the main structures are present out here, the branches or the tributaries of the vein move in and around the entire neck from this particular structure. So what are these structures? One is the carotids, which we are going to study, the internal jugular vein, the vagus. Now, they're all wrapped in a condensation of deep fascia, which is present out here, which is the carotid sheath. The carotid sheath extends from the base of the skull and goes, as some say, all the way down to the superior mediastinum, where the carotids are actually arising from the arch of, directly or indirectly from the arch of aorta. Now, depending at the level, now this carotid sheath is formed by, again, there are two views to it. One, de novo, that is just that the condensation of the fascia has taken place in this area. The other is that all the three layers of the deep fascia, that is the investing layer, the pretracheal layer, and the prevertebral layer, together form a wrapping in which these structures are moving. And the carotid sheath is very well developed along the arterial part of the sheath, but it is thinner on the venous side to allow for the veins for the internal jugular veins to dilate. It's not so well developed or so thickened. Now, in the carotid sheath, from the base of the skull to the, say, abhi hum root of the neck tak karte hain, to the root of the neck are present an arterial structure, is present an arterial structure, a venous structure, and this vagus. And they are constant in their position. The arteries are present medially. The venous structure, that is the internal jugular vein, is present laterally, and the vagus lies in between. At the base of the skull, certain structures traverse it. They enter and then perforate the sheath and move out. So what are the contents of the carotid sheath? At various levels, depending on the levels we are talking, it may vary. But what is it? The common carotid artery or the internal carotid artery, right? So the external carotid artery will not be a part of the sheath. So common carotid and the internal carotid artery, the internal jugular vein and the vagus. Along the internal jugular vein are present the lymph nodes, which are the deep cervical lymph nodes. Embedded in the anterior wall of the carotid sheath is the ansa cervicalis, which we saw in the last class, and related to its posterior wall is the sympathetic trunk, right? So it is present, as we discussed earlier, in the posterior lateral part. So the carotid sheath extends from above to below. Certain structures continue completely within the sheath. Some and their tributaries and their branches would perforate the walls of the sheath and move in and out. Now let's start with the carotid arteries. The carotid arteries, as we saw in thorax, arise from the arch of aorta, either directly or indirectly. On the right side, it is a branch. The right common carotid is a branch of the brachiocephalic trunk. It arises opposite the right sternoclavicular joint, and so there is only a cervical part of it. On the left side, however, it is a direct branch of the arch of aorta. There is a part of it in the thorax, which is the thoracic part, and thereafter comes the cervical part. Now, both the arteries, whether it be the right far side or the left side, enter the carotid triangles under the cover of the sternocleidomastoid and the omohyoid. So let's start by drawing these landmarks. So let's first make our two landmarks, which would be essential for us to be able to understand the positioning of the structures which is taking place out here. So we will draw the external acoustic meatus, and here let's draw the mandible. No, slightly lower. Let's also draw the mandible, the teeth which it bears. Now for our bearings, we will draw two muscles, that is the posterior belly of digastric as well as the superior belly of omohyoid, to have a little bit of understanding of the structures which are present. So we know that below the posterior belly of digastric would be the carotid triangle, and above it would be the digastric triangle. Then let's give it the intermediate tendon. So this would be the area near the hyoid bone, and then again the anterior belly of digastric. Similarly, let's put in the superior belly of omohyoid, which would be somewhere out here. And then let's again give it tendon. So the carotids of both the sides enter the triangle under the cover of the omohyoids, mainly the intermediate tendon of the omohyoid, and somewhere at the level of C4, that is the upper border of the thyroid cartilage. Now there is a variability to it, but we'll just take it as C4. They divide into an external carotid and an internal carotid. So it divides after a dilatation, as you can see, it divides into an external carotid and an internal carotid. Now, the external carotid artery is present anterior-medially, whereas posterior-laterally is the internal carotid artery. The name external and internal comes from the fact that it supplies the external structures of the head and neck, and the internal carotid artery supplies the internal structure, which is the brain, the cranial cavity on the inside. All right. So it's not on the basis of placement. So external carotid artery will show branches in the area of head and neck, whereas the internal carotid artery will traverse the entire canal without showing any branches. So it will go under the posterior belly of digastric, and enter in the carotid canal. So within the neck, this artery is not going to show any. So the carotid canal is more medial to the the opening for the carotid opening is more medially present as compared to the external acoustic meatus. So here would be the carotid canal somewhere. This is more medially and innerly placed, and this is the external acoustic meatus. So the internal carotid artery has traversed the neck. It arises at the level of C4 or the upper border of the thyroid cartilage, traverses the neck and enters into the cranial cavity. And this internal carotid, along with the common carotid, was lying in the carotid sheath. The external carotid artery, on the other hand, after it arises, it gives its first branch, the superior thyroid artery, which the moment it arises, it turns, as you can see, it turns, descends in the neck. So that's how we identify it. The artery which is descending in the neck, that is the superior thyroid artery. It is the first branch of the external carotid artery, and it also goes under the cover of the omohyoids to reach, and the other muscular triangle muscles to reach the apex of the thyroid gland. It is usually accompanied by a nerve, which is the external laryngeal nerve. So that is another landmark which we will need to remember. Thereafter, it gives rise to an ascending pharyngeal artery, which is a very small branch. This is the smallest, it's its smallest branch, which is ascending pharyngeal artery, which is present in between the external carotid and the internal carotid. So it's one of the medial branches. It is a medial branch and it goes all the way up. I'm not drawing it completely. This ascending pharyngeal artery. This ascending pharyngeal artery goes all the way up to the through the triangle, traverses the triangles and goes all the way. It goes all the way up and it sends branches, the meningeal branches, to the foramen lacerum. It also sends branches to the foramen lacerum, through the hypoglossal canal, through the jugular foramen. The meningeal branches of it goes through. But its main job is to supply the pharynx. So the ascending pharyngeal artery gives rise to pharyngeal branches to supply the pharynx, and gives rise to these meningeal branches which go backwards, which go upwards. Sorry, ये तो खुद ही upward जा रही है. It goes upwards and passes through these various canals. तो ये कौन थी? Superior thyroid, which is accompanied by the external laryngeal nerve. Just label this also. Otherwise, we'll have a problem later on. Superior thyroid. So I'm telling you its relevant landmarks so that you're able to recognize these when you come to us and you see the dissections. ये common carotid है. ये बन गई internal carotid artery. Thereafter, the superior thyroid artery gives rise to the external carotid artery gives rise to the lingual artery. The lingual artery first ascends, then descends, and then it again ascends. So it forms a loop-like structure, right? And then it goes deep to the hyoglossus muscle, जो हमने देखी थी, which was forming the floor, goes deep to the hyoglossus muscle and goes on to supply the floor of the mouth as well as the tongue. So this here is the lingual artery. It is crossed by the hypoglossal nerve and its accompanying vena comitatus. So the lingual artery, we need to remember, is crossed by the loop of the lingual artery is going to be crossed by the hypoglossal nerve and its accompanying vena comitatus. ये सब चीजें फिर हमें एक दूसरे को recognize करने में हमारी मदद करती है. Just and this lingual artery arises in front of the tip of the greater cornu of the hyoid bone. So lingual artery, ये उसके साथ, this is the 12th nerve, and its accompanying vena comitatus, and this is the tip of the hyoid, greater horn of the hyoid bone, which you need to be able to identify. Then it gives rise to a facial artery. Okay? So these are all, as you can see, branches which are coming from its anterior aspect. It gives rise to the facial artery. The facial artery moves all the way up. It goes under the digastric. It enters, goes to the angle of the mandible. So let's look at it here. Let's look at it here first. So this would be the facial artery. If you look at the facial artery, sorry, this is the facial artery. It goes all the way, it ascends almost to the area of the angle of the mandible. Then it goes, it's lying on all these structures where it's going to be giving rise to its branches, which are the ascending palatine artery, the tonsillar artery. Then it grooves the submandibular gland, which is present, and then comes to lie between the ramus of the mandible and the submandibular gland. And in front of the anterior inferior angle of the masseter, it becomes superficial and comes to the face. Thereafter, it runs on the face. Now, once it's lying in between the ramus of the mandible and the submandibular gland, it gives rise to this submental artery. So, the branches of the facial artery are important. These are the ascending palatine artery, which we just saw, the tonsillar artery. So, ये जो cranial part जो ascend कर रहा है, after it has arisen, and it's coming to lie close to the oral cavity structures, there it gives rise to this ascending palatine and this tonsillar artery. Then it grooves the posterior aspect of the submandibular gland, comes to lie between the submandibular gland and the ramus of the mandible, and then becomes again prominent in front of the anterior inferior angle of the masseter. Uske baad it comes onto the face, gives rise to the inferior labial, the superior labial, as well as the angular artery. And here it's giving rise to another branch, which is the submental artery, which will be running in the submental triangle, which we saw. Right? So now let's draw our facial artery. So the facial artery, again, it forms a loop. It is a tortuous artery. We saw that it formed a loop, and then it enters into the face. So here it is entered into the face, and this is the facial artery. It's a tortuous artery. So we'll pick it up. It's above, it arises above the lingual artery, and it follows again a tortuous course, which is first in the digastric triangle, and thereafter it leaves the digastric triangle and enters into the face at the anterior inferior angle of the mandible. And we've just done the branches which it gave when it was lying out here. They are important. Then, right opposite the facial artery, the external carotid artery gives rise to the occipital artery, which follows the posterior belly, the lower border of the posterior belly of digastric, then goes deep to it, and then it goes all the way up to the scalp. So it supplies the structures of the nape of the neck as well as the posterior inferior part of the scalp. This was the occipital artery. So it arose in the carotid triangle. It arose just opposite it's a posterior branch. It arose opposite the facial artery, but it ran posteriorly, and हम उसको कैसे identify करेंगे? That it's running along the posterior or the lower border of the posterior belly of digastric. Running along the upper border of the posterior belly of digastric is the posterior auricular artery. Another posterior branch, posterior auricular artery. Again, it went all the way up to the scalp. ठीक है? ये external carotid artery continue कर रही है. So this here is the posterior auricular artery, which runs along the upper border of the posterior belly of digastric, and this is also going to the scalp. So it's going to supply the skin on the lateral side of the skull or the auricle and go all the way up to the scalp. So these are arteries which are supplying the posterior aspect. Another important thing of the occipital artery is that while it's going out here, it goes medial to the mastoid process, and then it grooves the temporal bone. The temporal bone पर आप two grooves देखोगे medial to the mastoid process. एक जिससे posterior belly of digastric arise करी है, and दूसरी which is related to the occipital artery. Now, the external carotid artery has entered into the पेरोटिड रीजन, राइट? ये एक्सटर्नोअकूस्टिक मीएटस है, ये मैंडिबल है, तो ये यहाँ पर आ गई, ये पेरोटिड रीजन है. सो नाउ इट एंटर्स द पेरोटिड ग्लैंड का medial surface. So somewhere here would be the parotid gland. It enters into the parotid gland through its medial surface, runs in the parotid gland and divides into its two terminal branches. One is the superficial temporal and the other is the maxillary artery. So these are the terminal branches, which are the superficial temporal, which we saw on face and we discussed it, the superficial temporal artery, and this is the maxillary artery, which we'll be seeing when we study the temporal and the infratemporal area. So the external carotid artery gives rise to many branches which are present within the neck. These are the first branch, which is the superior thyroid artery. It's an anterior branch, which is going, as its name suggests, to supply the thyroid gland. So it descends. The lingual artery, which is another anterior branch, which as its name suggests, is going to the tongue. The facial artery to the face, again an anterior branch. Then it gives rise to a medial branch, which is the ascending pharyngeal artery, going on, ascends and goes towards the pharynx. It is present between the external and the internal carotid artery, and it's going all the way to supply the pharyngeal structures as well as the meninges. Then we had the posterior branches. There are two posterior branches. One is the occipital artery, going towards the scalp, and the posterior auricular artery, again going towards the scalp, and we know them by the relationships which they have with the posterior belly of digastrum. Then the artery itself enters into the parotid gland through its medial surface, posterior medial surface, and ends by dividing into its two terminal branches, which are the superficial temporal artery and the maxillary artery. So these are very, very important, the branches, and you have to know the branches. How you're going to recognize them, this is very, very essential. Okay, and this is the digastric posterior belly. At the carotid bifurcation, which is at the level of C4, are present two important receptors which are involved in reflex feedback mechanisms. One is the carotid sinus. The carotid sinus is a fusiform dilatation which is present at the terminal end of the common carotid artery and the beginning of the internal carotid artery. It monitors the blood pressure. A rise in blood pressure is accompanied by a consequent decrease in the heart rate and vasodilatation of the arterioles. This carotid sinus is innervated by terminals from the glossopharyngeal nerve as well as the vagus nerve, which are involved in the reflex mechanism. On the medial aspect of the common carotid artery is present a carotid body, which is a chemoreceptor, which is mainly sensitive to the oxygen tensions, but also to some extent to the increase in carbon dioxide as well as the pH of the blood. This reflexly controls a decrease in the oxygen concentration would bring about a reflex changes in the rate of respiration. It would bring about a change in the blood pressure as well as it will bring about the change in the heart rate, which is mediated by the glossopharyngeal and the vagus nerve again. So these are important receptors which are present in the vicinity of the carotid, or on vicinity of the common carotid. In many conditions, it is important to palpate the carotid artery, like while performing a CPR. Absence of carotid pulse means cardiac arrest, and it is usually palpated at the level of the upper border of the thyroid cartilage, and it has to be palpated gently. A rough palpation could result in a carotid sinus syncope. That is, there may be temporary loss or a hard palpation, temporary loss of blood supply to the brain, which could result in the person becoming unconscious. Or in our gentleman, whom we saw in the beginning of our lectures, in case you roughly palpate the carotid artery, it could result in dislodging of the emboli which is present, dislodging of the thrombus which is present in the carotid arteries. So it has to be palpated very carefully and gently, right? No rough palpation is required. The carotid body may sometimes have a tumor in it, which is known as the potato tumor, which you will read about as you go further in your course of MBBS. Then, as we've also seen that the carotid artery bifurcation is a common site of degenerative arterial diseases in which an atherosclerotic plaque may lodge in this particular area, resulting in decreased supply of blood to the brain, and hence, depending on which hemisphere is affected, what part of the brain is getting, which blood vessel of the brain is getting affected, the patient may show various symptoms like arm weakness, slurred speech, which we saw in our patient. Also, there may be visual impairments which may come in, because the ophthalmic artery is also a branch of the carotid artery, of the internal carotid artery. So it would also result, the reduced blood flow which is taking place in the blood vessel would result in disastrous consequences. And also this turbulent blood flow produces murmurs which can be detected by a stethoscope, which we called as a bruit in our case. Cerebral angiography can be performed by passing a radio-opaque dye through the carotids to localize tumors, blood clots, or space-occupying lesions in the area of supply of the internal carotid or the external carotid artery. Now, peeping into the neck, at the root of the neck is another structure, which is the subclavian artery. Now, we're not going to do it in too much of detail, but here's the relevant points about the subclavian artery. The subclavian artery, as you know, on the right side is a branch of the brachiocephalic trunk, which originates from the brachiocephalic trunk behind the sternoclavicular joint. On the left side, it is a direct branch of the arch of aorta. Now, from its origin, it is present in the root of the lung. It is present in the area of the root of the neck. And it moves from this area of the sternoclavicular joint all the way to the outer border of the first strip, where its name changes and it is now known as the axillary artery. Now, when it is on the first strip, as you studied earlier, here at the scalene tubercle was the attachment of the scalenus anterior. And behind this, on the groove on the first strip, the groove which is behind the scalene tubercle, that is where the subclavian artery was present. So the scalenus anterior crossed over the subclavian artery, and this scalenus anterior divided the subclavian artery into three parts. The part which is medial to it, that is the first part. The part which is posterior to the scalenus anterior, that is the second part. And the part which is lateral to the scalenus anterior, which is the third part. Right? Now the branches, let's do the so these are the three parts of the subclavian artery, and the subclavian artery is present behind the subclavian vein. Medially here would be the apex of the lung, and it was also, if you remember, grooving the medial surface of the apex of the lung. Now let's do the branches. From the first part arises the vertebral artery. We will just see the vertebral artery in detail. The vertebral artery, after it originates, enters into the foramina transversarium of the C6 cervical vertebra. Please remember, the foramina transversarium of the C6 cervical vertebra, not C7. All right. Then another branch of the first part of subclavian artery is the thyrocervical trunk. Again, artery which you've been seeing for quite some time. It gives rise to the suprascapular and the transverse cervical arteries. That is the cervical part of the thyrocervical trunk, which were going in the posterior triangle, which were running through the posterior triangle, and they were taking part in the anastomosis, which was present around the scapula. And the second one was the third branch of it is the inferior thyroid artery, the one which we did in detail when we studied the thyroid. So the thyrocervical trunk is another branch of the subclavian artery. The third branch is the internal thoracic artery, which we saw again in the thorax. So as you can see out here, from only this much, the branches of the first part only, that it is supplying the brain and the spinal cord, that is through the vertebral artery. It is also supplying the viscera of the head and neck, and it is also going in to supply the upper limb. Apart from the fact that वो axillary artery बन जाएगी और पूरी upper limb को supply करेगी, there are branches which are also helping in forming a connection and an anastomosis with the axillary part and the subclavian artery part of it. Okay, and it's supplying the chest wall. From the second part, which is behind the scalenus anterior, arises the costocervical trunk. Again, the costo part of this was supplying the first and the second intercostal spaces by the superior intercostal artery, which was formed, and the cervical part of it is the deep cervical artery, which supplies the posterior aspect of the muscles of the head and neck. And from the third part arises the dorsal scapular artery. So these are the three parts and the branches of the three parts of the subclavian artery. The vertebral artery is the first branch of the subclavian artery, which is shown in this picture in green. See, we usually show the blood vessels in the red, but here, in order to be able to distinguish between the two arteries, between the two arterial systems, the vertebral artery is being shown in green. The vertebral artery arises from the first part of the subclavian artery behind the sternoclavicular joint, near the sternoclavicular joint, and the moment it arises, it starts ascending. As we just discussed earlier, it enters into the foramen transversorium of C6 cervical vertebra. So this part, from its origin till it enters into the foramen transversorium of the C6 cervical vertebra, this part is known as the first. The second part, as you can see, which is running through the foramen transversoriums, runs almost vertically. It ascends almost vertically up till the C2 transverse process, foramen transversorium. Now from C2 to C1. Now this is behind the atlantoaxial joint, where the rotatory movements are taking place of head and neck. So in order to accommodate these movements, this artery now loops backward to be able, so that the atlantoaxial joint can move freely, and then it exits out at the atlas. Now this entire part was the second part. अब जब वो exit करके from foramen transversorium from the foramen transversorium of atlas, it's lying below the occipital bone. This part, which is present between the occipital bone and the atlas, this is the third part, and this part of the artery lies in an area which is known as the suboccipital triangle. The suboccipital triangle is made up of structures which are present between the occiput and the axis. Between the occiput and the axis is lying at the back of the neck, anterior to the trapezius or deep to the trapezius and the semispinalis capitis. The triangle itself is made up of these small muscles which are running between axis and atlas and the occiput, or from the axis directly to the occiput. Now these are small muscles which are involved in the extension of the neck. So unlike the muscles which we saw anterior to the vertebral column, these muscles were involved in the activity of flexion. At the neck, these muscles are involved in the extension. These small muscles are involved in the extension of the neck, and these muscles are, we are not going to do them too much in detail. Number one, the inferior oblique. The inferior oblique runs from the spine of the axis to the transverse process of the atlas. This muscle is forming the inferior boundary of the suboccipital triangle. So it is forming the inferior boundary of the suboccipital triangle and is running from the axis to the atlas. Now running from the atlas, transverse process of the atlas, to the area between the superior and inferior nuchal lines of the occipital bone is the next muscle, which is the superior oblique muscle. Now remember, these are inferior obliquus capitis and superior obliquus capitis, because the similar name muscles you also saw in eye. So this was the inferior oblique, which was forming the inferior boundary of the suboccipital triangle, and the superior lateral boundary of the suboccipital triangle is formed by the other muscle, which is the superior oblique. All right. Now running from the axis to the spine of axis to the area which is present below the inferior nuchal lines, laterally as well as medially, are two muscles which are forming the superior medial boundary of the suboccipital triangle. These muscles are the rectus capitis posterior major, and there will be another muscle out here which is present more medially, the rectus capitis minor. Rectus capitis posterior minor. So rectus capitis posterior major and rectus capitis posterior minor. Together they form this triangular area which is known as the suboccipital triangle, and lying in the suboccipital triangle is the third part of the vertebral artery. Now this part of the vertebral artery supplies all these muscles, and then in the floor between the occipital bone and the atlas is present the posterior atlanto-occipital membrane. So इसके posterior atlanto-occipital membrane को curve करते हुए going deep inside the foramen magnum, going into the foramen magnum, is the fourth part of the part of the artery which goes from here is the fourth part of the vertebral artery. Right. Now we just leave the vertebral artery at this point and take this structure. This is the dorsal ramus of C1, which is exiting through the suboccipital triangle, and it's going to be supplying all the muscles of the suboccipital triangle. Now the suboccipital triangle in detail, well, what is forming its roof, what is it forming its floor, what is forming its various boundaries, and whatever other contents of it, please see it from the book. I've just given you an overview of this particular triangle. You should know the exact boundaries and all. If you understood this, you will be able to take that part. And the how the nerves, the greater occipital nerves, are related to this particular triangle. Okay. Now let's go back to the vertebral artery because our focus was on the vertebral artery. Now the vertebral artery has entered into the foramen magnum. From here, once it's entered into the foramen magnum, it runs on the ventral side of the brainstem, and the two vertebral arteries of both the sides unite together to form the basilar artery. Now these vertebral arteries are supplying the parts of the cerebrum, they are supplying parts of the cerebellum as well as the spinal cord. And it was also supplying those muscles of the neck. So the vertebral artery arises in the neck and goes all the way up. It's a branch of the subclavian artery and ascends all the way up to supply the brain, and by this it does by participating in what is known as the circle of Willis, which is present on the ventral aspect of the brain, which is formed by the fourth part of the vertebral artery and branches of the internal carotid artery. If you remember, the internal carotid artery entered into the skull via the carotid canal. So अब ये दोनों join करके एक plexus बनाते हैं, the circle of एक anastomosis बनाते हैं, the circle of Willis, with the help of which they supply the entire area of the which they supply the brain, which you will be doing in detail in neuroanatomy. Now that gets us to another important component. We just saw that the brain was supplied by branches of the subclavian artery and the carotid system, right? Together they form the circle of Willis. Now for whatever reason, there is a thrombosis which can take place. If there is a thrombosis which takes place in the subclavian artery before the origin of the vertebral artery, मतलब subclavian artery block हो गई और अब vertebral artery में blood नहीं जा पा रहा, ठीक है? But ये vertebral artery we just saw took part in an anastomosis around the circle of Willis, which is the circle of Willis, with which it communicated with the internal carotid artery of both the sides, as well as it communicated with the vertebral artery of the opposite side. अब suppose left artery में block है and left artery से blood, subclavian artery से left vertebral artery में blood नहीं जा रहा. Now what does this vertebral artery do? This left vertebral artery starts stealing the blood or taking the blood starts flowing in reverse. It changes its direction of flow, and from the right side system, and from the brain and the internal carotid artery, it now takes a backtrack through the vertebral artery because subclavian artery still has to supply the upper limb. So it backtracks through the subclavian artery, it takes a backward flow and now goes into the subclavian artery, which is beyond the area of blockage So the vertebral artery is now supplying blood to the upper limb. It is going to be supplying the blood to the internal thoracic artery as well as all the other thyroid gland. So vertebral artery has stolen the blood which was meant for the brain or for the right side of the heart. Part of it is being stolen by it, and this is known as the subclavian steal syndrome. Now, because of insufficiency of blood to the brainstem as well as to the upper limb, it may result in brainstem ischemia as well as claudication and weakness of the arm, because obviously it was not going to be enough. So when we see symptoms, the patient complains of symptoms, or we elicit signs which involve the upper limb as well as the head and neck area, the brain region, then it could be a consequence of this blockage which is taking place in the subclavian artery, and hence the subclavian steal syndrome. These symptoms are dizziness, ataxia, vertigo. Dizziness means chakkar aana, ataxia again the same thing, vertigo, visual disturbances, because the brain is not getting its blood supply. So the ophthalmic artery, the internal carotid artery, that is we are taking away the blood from the internal carotid artery also. Motor deficit, again, brain has less blood supply. Confusion, aphasia, depending on which side of the brain is affected, headaches, syncope, arm weaknesses, and arm claudication with exercise, because the blood is not going to be enough. And it is usually treated by a carotid subclavian bypass. So now let's talk about the internal jugular vein. The internal jugular vein drains the brain, the anterior face, cervical viscera, and the deep muscles of the neck. It also drains the cranial cavity, parts of the cranial cavity, by means of the sigmoid sinus. So the sigmoid sinus continues as the internal jugular vein, and this happens in the jugular foramen, which is present in the base of the skull. So if we look at the base of the skull, there would be a foramina which is present. This part of its wall is formed by the petrous part of the temporal bone, while this part would be formed by the occipital bone, the basilar part of the occipital bone. And in between them is this foramina, which is known as the jugular foramina. This foramina is further divided into three compartments: an anterior, an intermediate, and posterior. Through the anterior exits out a vein which is the inferior petrosal sinus. It's a sinus. From the middle compartment exits out some cranial nerves, the 9th, 10th, and 11th. And from the posterior compartment comes out the sigmoid sinus, which the moment it comes out forms a dilatation which is known as the superior bulb, and then continues down as the internal jugular vein. Now this dilatation receives the inferior petrosal sinus. So the first tributary of the internal jugular vein is the inferior petrosal sinus, which is coming out from the anterior compartment of the jugular foramen. So look at this. Now, just get your bearings around it. This is the external acoustic meatus. This is the mastoid process. So somewhere behind, so you know that this is the occipital bone, and this here would be the temporal bone. उनके दो पार्ट्स है, द petrous part और उसका occipital bone का जो basilar part है, उनके बीच में यहाँ पर ऐसे ये foramen पड़ा हुआ है. This is the direction in which this foramen would be. Now, from its posterior compartment exits out the sigmoid sinus, which becomes the internal jugular vein the moment it exits out. It's a continuation of the sigmoid sinus, is this internal jugular vein. But before it becomes, at its continuation, it first dilates to form a bulb. A dilatation is formed, the superior bulb. And in this dilatation enters the first tributary, which is the inferior petrosal sinus. Thereafter, the vein exits, as you know, in the carotid sheath. It is present in the carotid sheath. So we know that the vein is present laterally, the arterial system is present medially, and the nerve, that is the vagus, is present in between them. We've already seen this. Now, around it, we also know that the condensation of the carotid sheath is not very well developed in order to allow for its enlargements to take place. Now, once it exits, it starts getting its tributaries. So the first one in the superior bulb was the inferior petrosal sinus. Now it's going to be in the area of the pharynx. So it's going to receive the pharyngeal veins. Then it's going to receive the facial vein. Do you remember the facial vein? The facial vein, which was formed by the facial vein as well as the anterior division of the retromandibular vein, joined together to form a common facial vein which entered into the internal jugular vein. Then it receives the lingual vein. Then veins of the thyroid, which is going to be present here, the viscera on the neck. So we have the superior thyroid vein, which would accompany the superior thyroid arteries, and the middle thyroid vein. And then again, it forms a dilatation, which is known as the inferior bulb, and then combines with the subclavian vein to form the brachiocephalic vein on that particular side. So the right or the left brachiocephalic vein. The subclavian vein, you're aware of, is a continuation of the axillary vein. Both the veins join together to form the brachiocephalic vein, which ultimately joins the right and the left brachiocephalic vein join together to form the superior vena cava. Right? So you've seen this part when you were doing thorax. Now look at this inferior bulb. This inferior bulb also has a valve in it. And this valve prevents the backflow of blood. Every time there is an increase in the intrathoracic pressure, the backflow of the blood is prevented by means of this inferior bulb of by means of this valve. Now, the internal jugular vein is a very good landmark to locate structures in the neck. Now, it's moving right. यहाँ ये ear cup area. So, जो lobule of the ear पर आप 1 point mark करोगे और sternoclavicular joint पर आप दूसरा point mark करोगे. And if you join these two points, that is where the direction of the internal jugular vein is in the body. So it's going to be overlapped at places by the sternocleidomastoid. It's going to get overlapped by the posterior belly of digastric and the superior belly of omohyoid. So that the intermediate tendon of the omohyoid. So the moment it gets overlapped, you know that okay, this part is going to be the part which is going to be in the carotid canal. This is the part which is in the digastric canal. So it's a landmark. इसके laterally हमको पता है, इसके medially हमको पता है the carotids are lying. Then उसके relation में we've seen how the inferior root of the ansa came in. What was the position of the superior root? So it's a very good landmark to make out the arrangement of the structures which are present in the neck. In most of the pictures, if you see, will have at least some end of the internal jugular. सारिया नहीं होगा, but कटा part पड़ा होगा, so that आपकी bearing बनी रहे neck में कि where are the structures going to be related in the internal jugular vein. Now, another very important structures which are related to the internal jugular vein are the deep cervical lymph nodes. So, on the superficial surface are present the deep cervical lymph nodes, which are the ultimate area of drainage of lymphatic, the smaller lymphatics. हमने देखे थे यहाँ पर submental, हम यहाँ पर देख रहे थे submandibular, यहाँ पर आपने देखे parotid. Ultimately, all of them drain into this deep cervical lymph nodes, which are present in relation to the internal jugular vein. One prominent one, which is present where the facial vein is entering, the common facial vein is entering out here, is the jugulo-digastric lymph node. This is also known as the tonsillar lymph node. Okay, if there is an infection in the tonsil, the first thing the physician will do is look for this particular lymph node, whether it is enlarged or not. It tells you about the duration, whether it's an acute infection, it's a chronic infection, the person has had repeated infections. So that tells you about it. Then another important one is the jugulo-omohyoid, which is present where the omohyoid muscle crosses over it. So these are important. These are two named important ones. There are a number of superficial lymph nodes which are present along the superficial surface of the internal jugular vein, and they may get enlarged in various disorders. And when removing it or taking a biopsy, we have to remember this relationship of these lymph nodes with the internal jugular vein. Now, internal jugular vein is also very important clinically. Usually we don't give the veins until they're very big veins so much of importance. The internal jugular vein is an important vein. Now, clinically also, you will be seeing it in your third year when you go into the clinic, especially when you enter into the medicine department. Usually, जब हम pulse देखते हैं, तो हम क्या करते हैं? We use the arteries to look at the pulse. Till now, we've been only talking about the arteries, but the jugular venous pulse is also very important. And usually, it is seen in this lesser supraclavicular fossa, which is present between the two heads of the sternocleidomastoid. You can see a slight pulsation of the internal jugular vein when the patient is kept inclined at a 45-degree angle, usually sometimes. Okay. If you see an enlarged, a higher presented jugular venous pressure, venous pulse, then it tells you that there is an elevation of the jugular venous pressure. And why is there an elevation? Now we just saw the jugular vein was in direct continuation with the right atrium. Okay, via the jugular vein, then the superior brachiocephalic, superior vena cava, ultimately we enter the right atrium. So in case there is any obstruction to the flow of the right atrium, there is an increase in the right atrial pressure, or the pressure is increased in the right side of the heart, at that particular point, the jugular venous pulse will be seen in the neck at a higher level. And that tells you, yes, that there is an increase in the right venous pressure. And this is a way of diagnosing an increased right venous pressure without having sophisticated gadgetry to assist you. So in case you're posted in a PHC or you're working somewhere where you do not have an access to the modern technological instrumentation, then it becomes a very useful method to find out the jugular venous pulse or the pressures which are present in the right venous chambers, right atrial, right heart chambers, let's say like that. Then another important thing which is done with the jugular vein or with the subclavian vein is catheterization. Okay, up to whenever you've seen catheterization or you would have talked about catheterization or read about the catheterization, you've seen that we've used the peripheral veins to do that. Now, in case a patient is admitted in the ICU where continuous monitoring is needed, or sometimes to measure again the pressures, which are present in the heart, or to administer drugs, drugs and fluids in case the peripheral veins are obstructed, then a central venous access is put in the patient. This central venous access means now you are catheterizing through the jugular vein or through the subclavian vein. So again, the placement of the internal jugular vein and the subclavian vein in the various areas, their placements, the relations of the structures which are present around it becomes of utmost importance when you're trying to catheterize either one of them, because you need to know that what are the structures which are present in relation to it so that you don't inadvertently damage it. With the jugular vein, you know that the carotids are going to be present. So you have to be careful that you do not injure the jugular vein and cause a hematoma to take place. With the subclavian vein, again, you are aware that there is the lung, the apex of the lung, the pleura which is present in its vicinity. So you do not want to give the patient a penetrating hemothorax or a pneumothorax because of your inadvertent injury. So the placement of these structures, the arrangement of important structures around them is important. We need to know. Then lastly, another important condition is penetrating wounds. In case there are penetrating wounds present of the internal jugular vein. Suppose we've injured the internal jugular vein while doing this catheterization. Now what happens is, now it's venous blood. So it's going to move in slowly into the surrounding tissue. So there is going to be a slowly expanding hematoma which is being formed. Okay, so we have a slowly expanding hematoma. And also because when the jugular vein enters, it pierces the deep cervical fascia and then enters into the subclavian vein, right? So when it does, it's piercing through the fascia. Again, the fascia is going to prevent its contraction and constriction in case there is injury. So as a result, the blood will continue to be poured into the surrounding deep cervical, into the surrounding facial spaces, slowly forming a slowly expanding hematoma. And from this opening which is now being created, which hasn't collapsed because of the less amount of smooth muscle which is present out here, as well as because you've gone through the deep cervical fascia, can also be the site of entry of the air into the jugulars, and from the jugular air can move into the brachiocephalic, it can move into the right atrium, resulting in, and then can move into the lungs, resulting in a condition which is known as the air embolism taking place. Right? So injury to the jugular vein can be fatal. So while performing the jugular catheterization or the subclavian catheterization, the surgeon has to be utterly careful. Now, before we end this lecture, let's just look at how the nerves in the triangles are placed. Now, the nerves in detail we'll be doing later on with appropriate lectures as it goes. So, I will be covering the 12th nerve with the tongue, and I'll be covering the 10th nerve with the thyroid. But Presently, we'll just see the disposition of how they are present in the 11th nerve we've already covered. So let's see the disposition of these nerves in the triangle. Again, just like I just told you earlier, that these structures, these cranial nerves as well as the internal jugular vein are exiting out from an area which is known as the jugular foramen. So यहाँ पर ऐसे एक jugular foramen, this would be the jugular foramen, and we will not take the 12th out of it. So if there is a 12th nerve which is labeled out here, oh, 1 minute. This is the 12th nerve. So the 12th is not coming out through the jugular foramen. The 12th nerve comes out through a hypoglossal canal. Okay, so there is a hypoglossal canal which is present medially, through which is coming out the 12th nerve. This carotid is entering into the carotid canal, which will be present out here. So this will be a carotid canal. So we are not talking about these, but we're talking about the other nerves which are present out here right now. We are talking about our 11th cranial nerve. We're talking about the 9th cranial nerve, and this is the 10th cranial nerve. We'll also look at this 12th cranial nerve while we go ahead. Okay, so the 9th, the 10th, and the 11th cranial nerves exit the base of the skull through the jugular foramen. The 12th comes out through the hypoglossal canal, which is present medially to the jugular foramen. Now, the moment they have come, they have entered into the carotid sheath, and then they pierce the anterior wall of the posterior wall, the side walls of the carotid sheath to move wherever they need to move. Now, look at this. They are in the carotid sheath, again present in between the internal carotid artery as well as the internal jugular vein. Now, firstly, the glossopharyngeal pierces the carotid sheath, that is the 9th cranial nerve, pierces the carotid sheath and moves along the stylopharyngeus muscle, which is arising from the styloid process. It moves along the stylopharyngeus, with the stylopharyngeus, in between the internal carotid artery and the external carotid artery, and goes on to the area of the tongue. Okay, so this is exited out or to the area of the pharynx. Wherever the 9th cranial nerve has to go to the posterior surface of the tongue, so it exits out and goes into that particular area. The 10th cranial nerve. Now look at the 10th cranial nerve. The 10th cranial nerve goes below in the carotid sheath between the internal carotid artery and the internal jugular vein. So it's running in the carotid sheath all the way down as we saw it at various levels. The 11th goes over the internal jugular vein and exits. It goes over the internal jugular vein and it goes and enters into the area of the posterior triangle. Goes under the cover of the sternocleidomastoid and exits, and you've seen its course. Ye 11th. So ye sab to is jugular foramen simply. The hypoglossal nerve. The hypoglossal nerve exits through the hypoglossal canal. Then after it's exited through the hypoglossal canal, initially it's present posterior to the vagus. Then it crosses, comes anteriorly, right? Then it comes into the area. It comes below the posterior belly of digastric. तो अब ये कहाँ आ गई? Carotid canal में आ गई. Then in the carotid canal, it loops forward. It further loops forward over the occipital artery, and then it loops over the lingual artery. And this is the loop which helps us to recognize the lingual artery as well as identify the hypoglossal nerve. This looping of the hypoglossal nerve over the tortuous lingual artery is a very good way of identifying both these structures. So this is what we have to identify. And I told you the hypoglossal nerve is the only nerve in the body which is accompanied by veins. The two vena comitatus should also be present with it. Right? And you can see that the hypoglossal nerve, when it's looping over the occipital artery, it's given its superior root of ansa cervicalis, which again is in the carotid triangle. ये देखो, ये posterior belly of digastric है. So anything below it is in the carotid canal, in the carotid triangle. Then also the vagus. फिर ये जो inferior roots आ रहे हैं, inferior root of ansa cervicalis बन रहा है, ये भी. So all these structures are in the carotid canal, and all these structures would be present in the digastric canal. So let's now, this is just a diagrammatic representation in case you need it for, if we need it for some answers. So you can make this. Now it's easy to make. I've helped you to make 1 or 2 diagrams. So you'll be able to make this diagram very easily to illustrate your answers. So now let's do the contents of the carotid triangle. Is the carotid sheath containing the common carotid artery and its branches, the internal carotid artery mainly, and external is usually outside. Maybe some parts of it initially may be present in it, but we know that the carotid sheath contains the common carotid artery and the internal carotid artery with the vagus as well as the internal jugular vein. Then the branches of the external carotid artery, that is the superior thyroid, facial, lingual, ascending pharyngeal, and occipital, are present in the carotid triangle. We just saw the internal jugular vein with its corresponding tributaries, the hypoglossal nerve and the superior root of ansa cervicalis. Some part of spinal accessory nerve may peep into it. Then branches of the vagus. The vagus also exits with the vagus also moves. While it's moving through the carotid triangle, it gives rise to its various branches. One of its branch we saw with the superior thyroid artery, the external laryngeal. So external laryngeal किससे आ रही है? Superior laryngeal से. तो वो external laryngeal, superior laryngeal, internal laryngeal, all these are also going to be present in this particular triangle. The deep cervical lymph nodes and branches of the cervical plexus are present in the carotid triangle. Present in the digastric triangle, that is out here, would be here. Now look at this. This is the digastric triangle. This is the digastric triangle, which is present out here. So you have the parts of the parotid gland, which is present. You also have the parts of the submandibular gland, which is going to be present. So we have the submandibular gland, the submandibular lymph nodes, and the facial vessels while they are moving on to the face, which are going to be a content of the anterior part of the digastric triangle. In the posterior part of the digastric triangle, we'll have the carotid. We'll have parts of the external carotid artery on its way when it's entering into the parotid, the carotid sheath and its structures. And also, अभी हमने देखा था जो external carotid और internal carotid के बीच में कैसे stylopharyngeus and glossopharyngeus पड़ी हुई थी, right? So एक और structure जो पड़ा होगा उसके बीच में will be the parotid gland. The parotid gland would also be present in between it, as well as some of the other structures of the styloid apparatus would be present in between the external carotid and the internal carotid. And now you can understand this very clearly because of the placement of how the structures are present. Also would be present the pharyngeal branch of the vagus. So with this, we come to the end of this lecture. So in your cross-section classes or in your dissection classes, you'll be seeing these various structures which you need to identify. Obviously, it's so much more easier in a diagram when you're seeing, but now on the basis of how the placement of the structure. So you can see the structure, how it's moving into the face, how it's dividing into the face into its various branches. So you immediately can recognize what is this going to be. This is going to be the facial artery, which is coming from the external carotid. This is the common carotid. This would be the internal carotid. And then look at this. This vessel is descending. The one structure which was descending, only one branch of the carotid was descending. That was the superior thyroid. So this is the descending branch. Then look at this. Right? Over the internal carotid and as well as common carotid, the superior root of ansa. This is the inferior root of ansa. So, these are the other branches. So, on seeing these structures, you should be able to recognize, and for that, we need to know the placement of structures as well as their little bit about their course so that we are able to identify these structures when we see them in dissection. So, thank you.